I'd like to welcome Dr. Suresh Vedantham, who is a professor of radiology and surgery at the Mallinckrodt Institute of Radiology and Interventional Radiology at Washington University School of Medicine. He's also the assistant dean in clinical research and the medical director for Center for Clinical Studies. Thank you for agreeing to do this podcast.
Thanks very much. Really a pleasure to be with you here today, Neil.
So before you were the lead investigator for ATTRACT, and I think everyone's familiar with the ATTRACT trial and the great stuff that it's really helped elucidate the treatment for acute lower extremity iliofemoral DVTs. Now you're working on a new project with C-Tract. Can you tell us a little about what C-Tract is?
Sure, yeah. So C-Tract is basically a multi-center randomized trial that's enrolling patients in the United States at around 30 centers. And it's focused on patients who have established moderate to severe post-thrombotic syndrome and iliac vein obstruction, defined as stenosis of greater than 50% or total occlusion. And patients in this study are being randomized to receive or not receive iliac vein stent placement, and they're being followed over a 2-year period. The primary outcome of the study is assessed at 6 months, and it's the change in the venous clinical severity score. We're also evaluating health-related quality of life, venous ulcer healing, safety, and costs, in detail, and also effects upon valvular reflux as well. So that trial has been enrolling for several years, slowed down a bit by the pandemic, as you might imagine, but has enrolled around 220 patients at this point. And which will make it, substantially larger than the two other randomized trials that have been done in this space. And we anticipate that the trial will finish later this year and then be published next year, hopefully.
So it sounds like you're almost across the finish line.
We never say that, and this is an NIH-funded trial, and right now there's lots of questions about NIH funding. So I'm pretty confident we'll get there. There's a lot of support for this trial in general, and so I think that somehow or other we'll find a way to get across. But it's definitely been a long and challenging road for sure.
So can you talk about how you foresee this trial playing a role in the management of chronic iliofemoral disease for patients and for practitioners both?
Yeah, so I think that there's two things to consider. One is the kind of narrow impact of the main trial findings, and the second is the secondary effects that can have. And I think that in terms of right now we've got a number of single-arm studies that have evaluated patients that have undergone stent placement with a similar condition and have demonstrated that there is clinical change that overall seems to be favorable over time. However, we have seen issues with stent patency in the post-thrombotic population specifically. And then secondly, of the clinical change and improvement that have been observed, we don't really know how much of it is the stent placement and the opening of the vein versus natural history, other treatments the patients are receiving, other changes in the patient themselves. They lose weight, they stop smoking, they get more active, whatever it is, right? So really discerning what's the treatment effect of stent placement and opening that vein. That's really what this trial is aimed to do. And it has a control group that's randomized to not get stented. And so we should be able to come up with a much better ability to discriminate how much of it is the stent and how much of it is other things. The second main impact, and the one that I'm even more excited about really, is that if we really think about it, only a tiny sliver of patients with this condition ever see a provider that even knows what this condition is. Post-thrombotic syndrome is simply not well understood among primary medical providers in the United States and probably elsewhere either. And right now, so few patients get any kind of care, whether it's compression, whether it's even just a basic understanding of what they're dealing with on a day-to-day basis in their lives. And so to me, really the biggest potential impact of a study like this is if it can get published in sort of a broadly seen medical journal, really would be to drive awareness of the condition and to enable more patients to get managed, whether that's by stents or in other ways. The bottom line is we really need people with this condition who are suffering with it to be able to get care from people that are knowledgeable. And so hopefully this can be a force that drives the awareness and that also drives education down the road.
So can you talk about some of the strengths of this study? Because it is probably, I believe, going to be one of the most powerful studies that that will be that we'll ever have in this field, quite frankly.
Yeah, I think that the strengths of the study, I would say, are that it's I think enrolling a relevant population. It's very different that ATTRACT was aimed at it was deliberately aimed at enrolling a broad population because the main question was, should we extend what we're doing to this new population? C-Tract is very different. It's focused on really the patients in whom we believe have a very good chance to benefit. Those who have iliac vein obstruction, who have moderate or severe symptoms, and who have good inflow to the common femoral vein. So people that have bad inflow veins are not being enrolled in this study. And so I think in terms of really giving us the ability to evaluate stent placement in a population that we feel so far, based on observation, seems to have been the population that may benefit the most. I think that this is a very tailored question looking at specifically that. I think the strengths really are in the fact that there's central randomization. There's a number of precautions against bias. The assessors of clinical outcomes are blinded to whether or not the patient got stented. The assessors of imaging outcomes are blinded to whether the patient got stented to the extent possible. Obviously, the ultrasound imagers are going to know because they'll see the stents. But in terms of event adjudication, things like that, the adjudicators are blinded. And there's a number of other precautions really against bias. We've also stratified the randomization so that there's an approximately equivalent number of patients with common femoral disease in both treatment arms. Again, the patients generally don't have femoral or deep femoral disease, but the common femoral can be diseased, but that's going to be approximately equivalent in both populations. So there shouldn't be any bias in the study from that factor, and we'll have the ability to do good subgroup analyses down the road. Similarly, we've stratified by the presence of an open ulcer at baseline so that there'll be patients with ulcers equally distributed in the two treatment arms. So I think that this will give us a good, fair test. We're using most of the sites have used FDA approved dedicated venous stents in study patients here. So it's kind of evaluating a relevant active treatment mode. And all the sites are required to use IVUS, intravascular ultrasound, in patients in the study as well. So really, we're using up-to-date methods as well. So
Um, After the procedures, what type of anticoagulants or antiplatelets are allowed or suggested in the trial? Because that's still a question that um, is debatable, controversial, and doesn't seem to have any consensus.
absolutely, yeah, yeah, and that was a question that we assessed carefully before the study. And what we did was we did it in several ways. One is that, of course, we surveyed our site network to get their thoughts on these questions. And we actually provided them very specific scenarios, clinical scenarios, for them to kind of assess what they would do. And then also we had an expert panel meeting that was kind of formed by the NIH, that was funded by the NIH, where we invited experts of different disciplines in to talk about some of the key questions, of which one of them was the antithrombotic therapy afterwards. So what we ultimately decided was that we really did want, at the end of the study, to have some ability to say the results of the study were obtained in people who were treated in a particular way. So that whether that was the optimal way or not, at least there's some sort of anchor to know, where to go from there. So in this study, people who get stented are required to receive both anticoagulant therapy and oral aspirin, 81 milligrams, for at least 6 months after randomization. After that, they can be treated per their physician's preference, taking into account their risk factors for recurrence in general. Patients in the control arm are generally treated by their physicians according to their risk factors, basically. But in the stented patients, they're required to get anticoagulants and aspirin. In addition, we've strongly recommended the use of low molecular weight heparin for the first 2 to 4 weeks after the procedure, to try and cover that initial period, since there's been a little bit of a trend among people that do a lot of these procedures in that direction. We don't have the firmest data there, but we felt it was kind of a reasonably good practice. And when you can get patients to do it, it's a good thing to do. So that's how the study is set up.
So I do think that your prior work in the attract trial and now the C-Tract trial are going to continue to push the ball forward. Looking forward, you have another trial, PE-Tract. Can you talk a little bit about the status and the goal, and just a little bit of what the next steps are going to be with the next trial?
Sure. Yeah. No, it's really P-Tract is really exciting, and I have to give so the chief kudos to Dr. Aki Sista from who's at Cornell University now and who was at NYU before. But he is the national PI of the trial, and I'm kind of his co-PI, national co-PI. But this is a trial looking at patients with intermediate risk pulmonary embolism, acute intermediate risk pulmonary embolism, and with an RV-LV ratio of at least 1. So they have kind of some evidence of right heart strain on their CT scan. And they're being randomized to receive or not receive catheter-directed therapy. And that can be either mechanical thrombectomy or catheter-directed thrombolysis per the operator's preference. And they're being followed for a year. And the very unique thing about the P-Tract trial, which is funded by the NIH as well, the very unique thing about it is that it's not focused mainly on short-term outcomes like most PE trials are. It's focused on kind of midterm outcomes. And so the primary outcome of the study is actually a two outcome study, which is basically looking at the peak oxygen consumption, meaning exercise tolerance, basically, on cardiopulmonary exercise testing at 3 months, and the New York Heart Association class at 1 year. And the idea is that the two outcomes are connected via what's known as a gatekeeping approach, whereby we're not going to hypothesis test the 1 year patient reported New York Heart Association class unless there is a statistically significant difference in the peak oxygen consumption at 3 months. The idea being that we know that there are many other conditions, other heart conditions, lung conditions that might affect the New York Heart Association class. We wouldn't want to conclude that, thrombectomy or whatever is effective unless there was a plausible biological, physiological reason to believe that clot removal is what produced that result. And so this was it's an adaptive design trial. So it's going to enroll between 250 and 500 patients. Interim analyses started at 250 patients, and then each 50 patients after that, their interim analyses. And right now, there are 298 patients enrolled in the study. It's been going really fast, actually, which is really terrific. And I think that's a real signal that the PERT network around the United States, the pulmonary embolism response teams that have been formed at different institutions are these just incredible. It's an incredible collaborative mechanism to advance care and to also drive enrollment in trials. And these randomized trials are very hard to do, but actually this one has enrolled really well. So I would anticipate enrollment hopefully to conclude in a year or so, and then maybe another year for follow-up. And in a couple of years, we will have randomized data of very high quality because it really is being done according to NIH production values, on the midterm effects of upfront clot removal and pulmonary embolism.
I love the fact that it's an adaptive design because I do think that that has certain advantages. And I do think that the work you've been doing is very notable. I think it's going to have some really great effects in terms of changing the route of that we take care of these patients, the way that we manage these patients and treat these patients. So thank you very much for talking about these different trials, and congratulations with hopefully finishing up with the C-Tract trial and the resumption or actually the continuation of the P-Tract trial because it sounds really exciting.
Yeah, thank you very much. Really appreciate it.